Today, we're very honored and fortunate to have with us Dr. Sood, who is an infectious disease specialist in Northern Orange County. There are 3 infectious disease specialists here, and Dr. Sood is on the staff at St. Jude Medical Center. He's a practicing partner in infectious disease consultants whose office is in Placentia. He's the co-chair of the Infectious Control and Antibiotic Stewardship Program at St. Jude Medical Center. He's a graduate of the Nehru Medical College in India. He did his residency in internal medicine at the University of Oklahoma, and he did his fellowship in infectious diseases also at the University of Oklahoma. He's board certified in internal medicine and infectious diseases, and he's been published in several medical journals, and he's here to talk to us today about a very cogent and critical disease process called shingles. So please welcome Dr. Sood.
Thank you, Dr. Lawton. Thank you for coming out today. I don't know if anybody has ever seen me in the hospital in my office here. No? Okay, well, that's good then. The less you see of me, the better. That means you're healthy. So, Dr. Lawton asked me to talk about shingles, specifically about what it is, why it happens, what's the treatment, and more importantly, is there anything that you guys or we guys can do to prevent it? So I will be talking about that. So what is shingles? So shingles is an infection that's caused by a group of viruses known as the herpes virus. And we're basically, for humans, the 2 important ones are herpes zoster. So that virus causes chickenpox if it's the first time you've had an infection. And in adults, if that infection is reactivated, we call that shingles. And so that's caused by herpes zoster. The other one that is clinically important for us is herpes simplex, which is in the same class, but it doesn't cause as severe disease as the herpes zoster. So the cold sores that most of us can get under stress, that's basically the herpes simplex virus that is causing that infection. Okay. So again, coming to the zoster virus, most of you, I presume, had chickenpox as kids. So that chickenpox is actually the herpes zoster virus that you guys got from somebody else. You know, many years ago, we didn't have the childhood vaccination that we do right now, so it was all infection that people were getting and transmitting it to other people. That's how I got it actually too. I mean, I was in class and the guy next to me had chickenpox, and ultimately a few days later I came down with it too. So when you're never exposed and you get exposed to this virus, then it causes chickenpox. So that's the childhood version of the infection. So what happens is that when you get exposed to the virus, you get the infection, you get over the infection, but the virus hides in our nervous system, which is the nerve network of our body. And it can stay there for very long periods of time. And that is important because as you get older, or if there are certain medical conditions that make your immune system weaker, then this virus gets the chance to come out again or reactivate, and that's what causes the shingles. So this is kind of a little version of our nervous system. So, you know, the brain is kind of the main part of it. And if you look down, it goes throughout your body. It's actually through the back. and you have these nerve roots that are coming out that supply every part of your body. So wherever you're having pain, that's basically your nervous system that's getting activated. And each line or each area that this nerve root goes down to, in the medical term, we call it a dermatome, which is the skin that is supplied by that nerve root of your body. So it starts in the brain, you have the spinal cord, and in the back, your spinal cord comes out, and you get these distributions throughout your body. So what happens, this is shingles basically, so what happens is that the virus reactivates. So you get the primary infection, it hides, or it's latent for a long period of time, but then in when you're old, or not even if you're old, if you're immune compromised, then that gives the virus a chance to reactivate, and that causes shingles. That's the medical thing that we get. So you can see the photographs. These are just some common areas and how it basically looks like. So I'm not sure, how many of you guys have actually had shingles? Wow, okay, so that's I know, I mean, I had never had it lately, but just like chickenpox, it's not a good disease to have, and I'm presuming you never want to have it again. I mean, that's the whole thing. So this is how it basically reactivates and what it looks like when we as physicians or your primary care physicians are trying to diagnose what's this rash that you're having. So let's come to diagnosis. So both chickenpox and shingles, they're a clinical diagnosis. You know, there's testing that we can do to get blood tests or a sample of the skin to look for it, but most of the times you can make the diagnosis by the presentation, by the history, and how that rash looks like, and what is your risk factors for shingles. So age, so the more elderly you are, the more likely it's going to be shingles. The history, how long has it been there, what are the symptoms, and the classical presentation of the rash and the vesicles, and the location. As you remember, if it's going down that nerve root, you're going to see it as a band of vesicles in that one area. So that is the classical presentation that we see for shingles. And that's all that you need to make the diagnosis most of the times, because the test will take time to come back, and by the time you get the test results back, then either it's gotten better by itself, or you should have given the treatment and the treatment course is finished. So really the blood test and the sample that we take are not usually very effective and not even needed most of the times. And again, because these blood tests take time, or these other tests take time to come back, we should not be delaying the initiation of treatment, because early treatment is the key to prevent complications from shingles, which I'll come to in a little while too. So most times, most physicians can easily diagnose shingles just based on the presentation and the history. So the other way to know what's the classical? There's some pearls that we have that guide us that this is shingles and this is not, say, a rash from some other medications. So most times, I would say more than 90% of the times, the rash that is associated with shingles does not cross the midline. So what does that mean? So again, the same thing is, this is a cross-section on the left of your spinal nerve root, which is in the back. It's kind of, basic anatomy, and you can see the bone. I don't have a laser, unfortunately, but so it's the bone, and you have the nerve roots in the bone, and the picture on the right again shows the same thing. So what happens is that when you get the primary infection, the virus will hide in that nerve root, and when it reactivates, it will typically reactivate only along one nerve root. Now, if you look at the diagram, these nerve roots, when they're coming out, there's one on each side of your spine. So if you cut your body in half, there's one on the right and one on the left. Typically, this reactivation will only cause one side to get reactivated. So as that virus is traveling down that nerve root, because the nerve root does not cross the midline, the rash is on one side only. You will not typically see it on both sides of the body or in multiple areas of the body. Now that is the most ways how people present, just one rash or like a belt or as a band of vesicles. But if you are very immunocompromised, so some people are on chemotherapy or they're on medications that really suppresses their immune system, they can have multiple areas that get affected. So again, if we're looking at where it can affect, you can see on the top left, you can see this infection around the right eye, the right scalp, because that's the nerve that gets infected or reactivated in this patient. And the other two are common ones that are found on the chest and on the back. But you can get them in any part of the body, leg, thigh, face, brain, eyes. So basically anywhere you have that nerve root that's supplying or that's supplying that part of the body, that nerve root can reactivate and cause shingles. So again, as I said, only usually one nerve root is affected at a time. But in a very few proportion of patients who are severely immunocompromised, such as people who are on high-dose steroids. So a lot of people have COPD, and they're on steroids to help the breathing. So if your dose of steroids is very high, that actually causes your immune system to get weaker. That's just one of the side effects of being on those steroids. Or if you have an autoimmune disease, people who have lupus, rheumatoid arthritis, they're on steroids for that, but they're also on these newer biological agents, Enbrel, Humira. These all weaken your immune system because that's what's causing you to have the lupus. Your immune system is too active. But the downside is that if you weaken your immune system, you've made yourself more prone for certain infections, and shingles is one of them. Patients on chemotherapy for their cancer, that also reduces or decreases the immune system and makes them more likely to do that. So these people are the ones where it is more likely to cause disseminated disease, meaning more than one nerve root is affected, so you can get it all over the body at once. I've seen a few patients over the last 15 years that I've been doing this, where they come in with a whole body rash, just like chicken pox, where it's all over. And that is really, really bad because the pain associated with that is not very good, and it's very debilitating. And most times these people have to be in the hospital for treatment. So if you just have localized shingles, most times that can be taken care of by your primary care physician or whoever in the outpatient setting. You don't have to be admitted in the hospital for treatment. But if you have the disseminated shingles, then definitely you have to be in the hospital because you have to get intravenous therapy for treatment. So what symptoms do people usually get? Most times they get what we call this prodrome of symptoms, meaning they just start feeling unwell. They don't know what's going on. They just sometimes loss of appetite, fatigue, some low-grade fevers. They get pain and itching along the nerve root where the shingle is about to show up. The thing is that a lot of times these symptoms will even happen before you notice the rash or the blisters or the vesicles associated with shingles. So a lot of times you may feel that maybe your shirt is tight, or something's biting you, or it's just you're scratching, but you don't see anything over there. There's no rash. And that's very typical of this to happen. And again, depending on which part of the body is or which nerve root is getting infected, that's where you're gonna start noticing the itching and the pain. And about 2 or 3 days later, the rash will show up, the blisters and the vesicles will show up, and those vesicles go through a natural progression of scabbing off as the disease progresses, basically. But again, most times you'll have this pain and itching before you even see the rash. So that's very key in getting the diagnosis, because again, early diagnosis and treatment prevents complications. So why is treatment and why is diagnosis early important? It's because it can decrease the duration of symptoms. So instead of having a longer course, your symptom duration will be less. It can decrease the chance of transmission. So if you're in a household or there are people, say, in nursing homes, these vesicles are very contagious. So if you do not get early treatment, then you're more likely to give it to somebody else. But the main benefit of early diagnosis and early treatment is that you can try to prevent damage to that nerve, because there's a condition called post-herpetic neuralgia, which basically means post-after, herpetic meaning the disease, the herpes infection. Neuralgia means pain along a nerve root. So as this virus has activated, it causes damage to that nerve root that where it has reactivated. And once that damage has occurred, the pain associated with that damage will persist even after the shingles has resolved. And that can happen in more than 50% of patients who get shingles. The problem with that is that that pain can last up to 6 months, 1 year, and sometimes lifelong. And the only way to counter the pain is you have to keep taking pain medicine. There's no way, there's no other thing that will make that pain go away. Now, over time, the intensity might get less, but sometimes the intensity stays the same depending on your age, depending on your vaccination status, and depending on how early you got treatment once the infection started. So that's why it's important to know about it so that you can get the treatment as fast as possible. So what is the treatment? It's a virus, so the treatment is antivirals. There's 3 oral medications that we have. Acyclovir, which is the oldest one of all of the 3. It's usually the cheapest, but the problem with acyclovir is you have to take it multiple times a day, sometimes up to 3 to 5 times, depending on your age and your kidney function. The other 2, which is valacyclovir and famciclovir, they're prodrugs of the acyclovir. They're a little bit newer. They're also generic now, so not as expensive as they were maybe when they came out. But the benefit is you don't have to take it 3 to 5 times a day. Most times you can take it once or twice a day, and it can still be effective enough. So all the physicians, primary care physicians kind of know about this. They know the dosages, but it just depends on the cost, which one is best for you. The only intravenous medicine that we have is the acyclovir form. The other 2 do not come in an intravenous form. So if you have the disseminated disease and you're in the hospital, while you're very, very sick, the treatment would be giving you the intravenous form of the acyclovir. Or if you're vomiting and you can't take the oral, even if you're at home, then you might need to be on the intravenous for a while until you're able to take the oral medications again. The duration of treatment, usually 5 to 10 days. but it can be longer depending on how severe the disease is. Typically, just localized shingles, usually a 5 to 10 day or 7 to 10 day course is more than adequate to treat the disease, basically. So I was talking about complications. So what happens? So if you get infection of the eye or zoster of the eye, it can lead to blindness. I've had maybe one patient that had it pretty bad and unfortunately led to blindness. If it affects the nerve in your ear, you can have loss of hearing. So that is not good. And again, the post-herpetic neuralgia is what I was talking about. So about 1 in 5 people may develop this. And this is not something that you want because you then become dependent on pain medication. And sometimes you have to keep the dose going up and higher because you start developing tolerance to the pain medicine. So in every couple of months, you need more and more of the same medication to get the pain under control. If it goes to your brain, it can cause encephalitis. People become comatose, they become confused, and sometimes people have died from it. But again, with treatment, you can maybe alter the course of the disease. It is still treatable, but it depends on how fast the diagnosis is made and how fast the treatment is started, because that is very important. So the final topic is the vaccination. So now in the US, we have a childhood vaccination for chickenpox. Most kids will get it, so that they don't have to deal with the disease. So you're basically fooling the body's immune system to make antibodies against the virus so that you're protected from chickenpox, even if you get exposed to it when you've never been exposed. So I won't talk about that. But coming to the adult vaccinations, we now on the market have 2 vaccines. The first one is called Zostavax. It's a live virus vaccine. This came out more than about 10 years ago, the first adult zoster virus that we had. And most recently, in the last 2 years, we've gotten this other vaccine called Shingrix. But this is a recombinant vaccine, and I'll talk about that. So Zostavax licensed in 2006. It's a live virus. So people, when they did the studies, they saw that people who got the vaccination, they could reduce their risk of getting shingles by almost 50% compared to people who did not get the vaccination. That was the important part, but the more important part is that even if you got shingles and you got the vaccine, you reduced your risk of getting the post-herpetic neuralgia by almost 65%. So the benefit was twofold. It was not only preventing the disease, but also even if you got the disease, you would have a less likelihood of getting the post-herpetic neuralgia. So it was very good. So it's been licensed for people over the age 50, but we have a committee called the American Committee of Immunization Practices, the ACIP committee. They recommended to give it for age 60 or older. The protection will last about 5 years, but there's no recommendations for revaccination at this point in time. Now, even after 5 years, it doesn't mean that you're not protected, but we know that after that, then your immunity or the vaccine benefit does go down after that. But again, it's still better than nothing. Coming to insurance coverage for it, Medicare Part D does pay for it, but again, the cost is dependent on your plan and other factors too. Medicare Part B doesn't cover it. Private health insurances may cover the vaccine for 60 years and older, but some plans, even if you're over 50, it will cover it between 50 and 59 years. So, but that your insurance will depends on what insurance you have. This was a newer vaccine, the Shingrix vaccine. So this is a recombinant virus. So the Zostavax was a live virus. It's basically live viruses that you're injecting into yourself, And again, you're having your immune system make antibodies to protect you. The recombinant one is that it's not a live virus. They're just taking proteins from the virus and using that to stimulate your immune system. So the benefit of this is that because it's not a live virus, you can give it to people who can't take live viruses, and therefore you can cover a lot more people with this vaccine rather than the Zostavax vaccine. Now, it's so effective that you can't get it because it's not available. People are just using it so much. Even a lot of my patients, and I mean, I don't give the vaccine in my office because of kind of insurance reasons and everything, but whenever I've recommended it to my patients, they're saying that my pharmacy doesn't have it, my primary care doctor doesn't have it, we're on a waiting list to get it, and that's how good it is. So, but again, it's good because it works better than the Zostavax vaccine. So the CDC recommends that adults 50 years and older get 2 shots of it, 2 to 6 months apart if you can get it. But look at this. 2 doses of the vaccine can prevent the post-traumatic neuralgia by 90%. With the Zostavax, we saw 65%. With the Shingrix, we're seeing a 90% reduction in that post-traumatic neuralgia complication. So this is great data for that and why people should be getting it, again, if they can find the vaccine. So who should get the Shingrix? So even if you've had shingles, you still should get it because it can still protect you a lot better even after a shingles attack. If you've gotten the Zostavax, you were the lucky ones that got it when it got out, you should still get it because it does provide additional benefit. And even if you're not sure, so some people say, I've had shingles, or I've had chickenpox, and I don't need it. The CDC recommends that even if you've had those infections, you should get the Shingrix if you can, basically. Again, for Shingrix, Medicare Part D will cover it. Part B doesn't cover it. Medicaid may or may not cover the vaccine. So it just depends on your plan, your health insurance plan, and that's something that you can figure out by calling your insurance. So that's kind of almost the end. So just about vaccinations in general, as an infectious disease doctor, I promote the use of vaccines because from my point, I think that is the best way for preventing infections and keeping everybody healthy. We've seen the current state of measles outbreak, which was a disease that we thought we had eradicated, and now we're seeing this huge influx of measles throughout the country because of kids not getting the vaccination for XYZ reason. But vaccines are key for disease eradication, at least infectious disease eradications. So can anybody tell me which is the only human infection that we have so far eradicated with vaccination? Very good, very good, very good. So that's the only disease. Now we want to do more. We wanted to eradicate polio. We've been wanting to eradicate measles, mumps, rubella, but we're not at that stage yet. And whether we're going to be able to do it, I don't know. It depends on how everybody feels about vaccination and what's going to happen down the road. So, in summary, shingles is a debilitating infection. Nobody should get it because it is very bad. Again, mainly affects people, elderly patients, patients with compromised immune system, but anybody can get it. Early diagnosis and treatment is the key for reducing the duration of the infection and in reducing the complications from it. And we do have vaccines available if you can get it, and they are very effective. So, I think that is the end of my talk. Questions? We will start here. So, yes, sir.
I have a question. If someone's on medication methotrexate or rheumatoid arthritis, and their rheumatologist says, well, you shouldn't get the shingles shot because your immune system has been reduced. The first one you said is a live virus, but is it safer to go with the Shingrix, or is it the same thing? The doctor's going to say no.
So the question was that if you're on methotrexate, which is a medicine to treat rheumatoid arthritis, whether or not it's safe to get the shingles vaccine. So to answer that question, methotrexate is not as, doesn't compromise the immune system as much as, say, high-dose steroids or some of the newer agents. So you should get Shingrix if you're on methotrexate, and there's no contraindication to even getting the Zostavax if you're just on methotrexate itself. Again, it kind of boils down to risks and benefits, but I think that if you can, the option would be number one, Shingrix. If you can't do that, get the Zostavax. If Shingrix is not available or you can't do it, basically.
And you said if a person gets I got the Zostavax, you said, oh, we're not recommending after 5 years get another one. So are you recommending to get the Shingrix?
So the question is, if you've already got the Zostavax and it's been even less than 5 years or more than 5 years, should you get the Shingrix? And the answer is yes, because it's still, it's a different form of activating your immune system. So you're not going to do any harm by doing both, except to your wallet. Yes, correct. Again, the Zostavax was a live virus vaccine, so your chance of getting side effects would be much more from that. Again, there's nothing that's 100%. Even if you look at all the studies and they say that only 1 in a million patients get this big rash, if you're that one patient, then your chances of side effects is unfortunately 100%. So, but that's a conversation you have to have with your physician to look at the benefits of the vaccination versus what is the perceived risks or the side effects, and then decide as a joint conversation whether you should get it or not. Yes, sir. So the question was that the neighbor whose daughter or son was 16 got shingles in the eye, and the question is, should she get the vaccine? The simple answer is, I don't know if she was vaccinated for chickenpox as a kid or not, because that would make a difference. The two vaccines I talked about, they're only approved for people 50 years and older. So they do not have studies for people less than 50. So I cannot advise that they should get that. The question is whether or not they've had their chickenpox vaccination, then the answer is yes, they should get that if they haven't had that. Yes, ma'am.
Two questions. Number one, if you get the first Shingrix and you're unable to find anybody that can give you the second one in the appropriate time span, what does that do? And in your opinion, you would think the drug company would be manufacturing day and night since there's such a huge demand, and when are they going to catch up? Right.
So the question is, if you got the first Shingrix vaccine and you're unable to get the second dose, whether that's because of whatever XYZ caused what to do. And the second question was, why is the manufacturer not making more of the vaccine? So unfortunately, I cannot answer the second question because I don't know why. I think they've got their reasons and everything. So to answer the first question, what to do if you don't get the second one? Unfortunately, since you got the first one, you still have benefit from that, and you just get the second one as soon as you can. You don't have to restart the whole series again.
Even if it's after 6 months or 8 months or...
Correct. Yes. Yes.
I got the first one, and they didn't tell me I had to get the second one.
You mean you got...
It's been about a year or two since I got the first one. Do I need to repeat them both?
The first one meaning the Zostavax vaccine or the Shingrix vaccine?
Shingrix.
Okay. So yes, the recommendations are the booster vaccine 2 to 6 months later. So if you haven't got the second one and you can get it, then you should. But if you, again, it's so hard to find it, unfortunately, at this point.
So if it's been more than a year, you should get 2 again?
No, you don't need to restart again. You just get the second dose only. Yes, ma'am.
Aside from the side effects we talked about already, are there any other risks with that vaccination? And what if you've taken prednisone in the past? Does that compromising?
So the question is, are there any side effects from the vaccine?
Not side, you talked about side effects, risks.
Oh, risks of the vaccine. And the second question is if you've taken prednisone in the past and currently not on prednisone?
Right.
So again, the Zostavax, which was the older vaccine, did have higher chance of side effects because it's a live virus. So we know live viruses have more likelihood to cause, are more likely to cause infection because they're live viruses. The Shingrix, we're not going to get that because it's a recombinant virus, so you're not going to get, it's a protein of the virus, not the actual live virus. So you're not going to get reactivation. You're not going to get shingles with the Shingrix vaccine like you could with the old vaccine. And again, again, there's no medicine, there's no vaccine that's 100% safe. So, but again, it's the whole thing of what is the potential benefit and what is your perceived risk, and that's something as a conversation with your physician you do. And coming to the prednisone, even if you're on prednisone, you can get it. And actually, if you are on prednisone, you're at risk to getting shingles, so you should be more likely to get it than somebody that's not on prednisone, whether it's in the past or currently. If you, yes, ma'am.
I want to know, how is shingles affecting the world? They just had on television a couple days ago, if you were at LAX, you were exposed to measles.
So the question is, how is shingles affecting the world? So, fortunately, shingles is not as contagious as some of our other infections, such as measles or tuberculosis or whooping cough or diphtheria. From a global health perspective, it's not the most raging infection that we're worried about from a public health issue. It's more of individual patient because it's not the disease that we worry about, it's the complications from the disease that are more worrisome. If you get it, even if you don't get treatment, you'll get better. Just the complications are what you want to prevent by treatment and by vaccination. But the other diseases, measles, diphtheria, tuberculosis, those are much more easily transmissible between patients. And so those are kind of the ones that we're trying to eradicate or contain as much as we can. But again, there's two sides of the story for that too. Yes, sir.
I'm guessing, just like cancer, the doctors don't know where that nerve is going to predict to go, whether it's going to go to your eye or your ear or your chest, or if there's any cause of where it might. I have a friend who had it in the eye, and another friend had it in the scalp. And none of us want to go blind or deaf or into the brain. There's no probable way of determining where it might want to go.
Even if there was, you couldn't do anything different. The only thing you would still do is you would do the vaccinations for prevention. But the key is early treatment to prevent the complications. But there's no way to predict where it's going to affect, unfortunately.
What's early?
Early is as soon as possible. So if you get that prodrome symptom, you're getting that itching feeling, you're getting the pain, and then you see the vesicle. As soon as you see the vesicle, you get the treatment. Okay, one other please. The question is, if you've had chickenpox more than once, does that make you more prone for shingles? And the answer is no. It's more of what your current situation is rather than what you've had in the past. Yes.
I'm wondering, I have a friend who got shingles after very high stress episode in his life, so does stress add to the possibility?
The question is, does stress add to your probability of getting shingles? And the answer is yes, because any stress will cause your immune system to weaken, and that's what it takes for the virus to reactivate. So marriage is one of them that I say. Yes.
You may have addressed this, I'm not sure, but for those who are more immunologically compromised than just being older, i.e. I'm thinking of the blood cancers, but not on medication yet, is there a potential that if we contact the doctor, there may be some dosages reserved for those kinds of people? Or, we're on a waiting list forever, like everybody else.
Dosages for what?
Dosages for people who need them more.
For the vaccine, you mean?
For Shingrix, I'm sorry.
Oh, unfortunately, no.
Okay. I didn't think so, but it was worth asking.
Do we have any more? Yes.
How is shingles contagious? How is it spread?
So the question is how is shingles spread? Because the vesicles have the active virus that is replicating. So when you have the blisters and if they open up and you're touching and you can inoculate yourself or you touch your eye, and basically you transfer that live virus to your own body. Again, it's very rare to happen, but once the vesicles have scabbed over, then you're not considered contagious anymore.
So how many days would that?
It can take anywhere from 5 to 7 days because the vesicles, they go through a phase. So depending on, because sometimes you get different days when the vesicles come up, so it can last for up to 5 to 7 days.
So somebody else has to touch an open vesicle
Correct.
to
And again, at home, really, it's not, I mean, when you're at home, it's not that bad because you're doing hand washing and everything. And we're more concerned when you're in the hospital because you have all these other sick patients there, so you want to make sure that you've done the correct isolation precautions to prevent spread to other unhealthy individuals that are admitted in the hospital. Yes, ma'am.
I don't know what the status is now, but I understand some of the doctors in other countries, especially Germany, were opposed to this, to the Shingrix.
So the question is that physicians in other countries are opposed to this. I mean, that's a personal belief, and so I just know that the only way we can eradicate disease is by vaccination. Yes, ma'am. So the question is, they have active shingles, can they transmit chickenpox? So they're both the same disease process caused by the same virus. It's just that if it's primary infection, it's chickenpox, and if it's secondary, shingles. But you can theoretically get it, someone who's not ever had exposure to it. If you are in contact with somebody with shingles, then yes, you can get chickenpox from that same virus.
I have one question. It used to be that there was talk of using high-dose steroids at the very earliest sign of shingles.
I'm not sure. I've never used high-dose steroids for my patients. I think that was probably to reduce the risk of complications over time, but I don't think that there's been any good studies to prove that that's actually beneficial.
Okay, great.
One more.
You mentioned that if you can get, or I guess if you have contact with someone with shingles, if you can spread, what type of contact do you need? Just by the breathing or?
So it depends on, so the question is what type of contact you need. So if you have disseminated shingles, meaning all over the body, you can get infections even in the lung and transmitted by the aerosol. Now, it's very, very rare to see that because it's very, very uncommon. So most of the transmission that would happen would be from the open vesicle of the lesion. Other than that, really, there's no other way that it would really transmit. But again, it's not a virus that easily transmits, so really we're not that concerned as compared to some of the other like measles, diphtheria, tuberculosis, because those are respiratory ones and they can linger in the environment a lot longer. So those are a lot more contagious and infectious than shingles. Yes, sir.
One more.
So again, the question is when you get the treatment. Again, I can't, I mean, if you come to me with chest pain, I would say, well, it's probably a heart attack and go see your cardiologist. Again, the problem with shingles is that, again, if you're getting a rash, I think your doctor should tell you, look, this may be X, Y, Z, right? I mean, if you don't have anything going on, it's very hard to say. I mean, it could be an insect bite, although you would see probably a rash by the time you have the itching. So you have to have that high clinical suspicion, and just because you have pain and itchiness doesn't mean that you should always get the medication, because the medications are not benign. They have their own side effects. But if what I would say is if you tell the patient, if you see a vesicle forming, I'm going to give you this prescription, you go start the treatment. But if you don't see the vesicle, then you don't need to take medicine unnecessarily.
You mean a blister?
A blister, correct. A vesicle or blister. Thank you.
Thank you very much. That was a great presentation.